morning and welcome to a new episode of Medisch Kompas. My name is Sarah.
And I'm Henry.
Today we have a very nice and special episode. We have today with us Professor Jean-Frédéric Colombel. Jean-Frédéric Colombel is professor at the gastroenterology at the Icahn School of Medicine at Mount Sinai in New York and director of the Susan and Leonard Feinstein Inflammatory Bowel Disease Center. Trained in Lille and Paris, Jean-Frédéric Colombel previously served as professor and head of gastroenterology at the University Hospital in Lille, France, before moving to Mount Sinai to help build one of the world's leading centers for Crohn disease and ulcerative colitis. His work focuses on the pathogenesis and treatment of inflammatory bowel disease from genetic and microbiome discoveries such as NOD2 and ASCA to landmark clinical trials of biologics and small molecules that have reshaped modern IBD therapy. He has led major international IBD consortia, including GetAid and the European Crohn's and Colitis Organization, and is among the most widely cited researchers in gastroenterology with over 1,000 peer-reviewed publications.
Enormous welcome. And just to start off with, could you give us a broad understanding of what inflammatory bowel diseases are and your understanding of them?
Thank you so much. Thank you for having me today. So I'm happy to discuss about inflammatory bowel diseases. So as you know, we are talking about two different diseases, Crohn's disease and ulcerative colitis. Both diseases were actually discovered in the beginning of the 20th century. Ulcerative colitis first, and then Crohn's disease by Dr. Beryl Crohn, who was a gastroenterologist at Mount Sinai, where I'm here now. So there are differences and similarities between those two diseases. They are both considered as basically immune conditions, meaning that they are mediated by an abnormal immune system in the gut. The main difference between ulcerative colitis and Crohn's disease is that ulcerative colitis always involves the rectum and the large bowel, the whole large bowel or some part of the large bowel, while Crohn's disease actually can involve from the mouth to the anus. So it can be much more extensive than ulcerative colitis. There are very interesting similarities between those diseases because when you have one of these, you can get another one more often than expected by chance. And actually, this is an area of research because we suspect there are common pathways that can basically lead to the development of these immune-mediated disorders.
Mm-hmm. And could you then give us a sense of what those common pathways are and how they lead to the pathophysiology of ulcerative
we don't
colitis?
know yet. Let's, for instance, concentrate on Crohn's disease. Crohn's disease results from an abnormal immune response of your guts to, very likely, your microbiome. Your microbiome, as you know, there are many bacteria in your gut, on the influence of genetic and environmental risk factors. So as far as genetic, for instance, for Crohn's disease, we discovered the first gene, which was a susceptibility gene for Crohn's disease in 2001, which is called NOD2. But since almost 300 susceptibility loci have been described. So it's not one gene, one disease. It's a polygenetic disease. And the genetic is playing a role, but not a major role in the development of the disease. It accounts for approximately 15% of the risk. Then, as far as the environment, there is huge interest in the environment, especially because what we see now is a spreading of those diseases all over the world. You know, they were originally described in Europe and Northern America. It was the first wave, and now we are contemplating a second wave occurring in countries such as India, China, Africa, South America. And of course, this immediately raises the question about environmental factors and especially diet. We suspect that change in diet may play an important role in the occurrence of those diseases, especially more processed food, inflammatory diets, and less actually good food natural food. So this is certainly an important environmental role.
So you mentioned the effect of food intake. Is there something known about on which life stage this has most effect?
This is a very good question. Actually, you are right. And this is true, I believe, for most immune-mediated diseases, that early life is key. Early life meaning even during pregnancy and babies and childhood and adolescence, because this is when you are shaping your immune system and your microbiome. So there are a lot of data actually showing that depending on your diet, use of antibiotics, excessive use of antibiotics, for instance, is certainly a strong risk factor for developing Crohn disease. There may be also some problem with pollution, exposure, to the new chemicals, what we call PFAS, pollutants, microplastic, and so on and so forth. So you are absolutely right. This is a key area where people who are genetically predisposed are exposed to those environmental factors, including smoking, even passive smoking, and this is increasing the risk of developing Crohn disease or ulcerative colitis.
On smoking, what's interesting about it is that sometimes it can be protective and sometimes it can be predisposing.
You are right. This is actually fascinating. Strikingly, smoking is a risk factor for Crohn's disease, but is a protective factor for ulcerative colitis. So, for instance, the risk of developing ulcerative colitis is particularly high in heavy smokers who stop smoking. And we don't know why. Another fascinating observation is the role of appendix. So if you have appendectomy before the age of 20 for appendicitis, this is a protective factor against ulcerative colitis.
Yeah. Maybe then for the diagnostics, could you describe what the mainstay of diagnostics are and how you'd approach a patient who presents with inflammatory bowel disease symptoms?
This is a very important point. The main problem is that outside bleeding, most of the clinical features of IBD are not specific. Imagine you have abdominal pain or you have abdominal pain, some diarrhea, losing weight. You say, okay, it's stress or I had a bad bug and so on. And then you are not consulting and so on and so forth. And then we are losing time. So this is a very important problem. So, which is a delay between symptoms and diagnosis. And believe it or not, in the US, 50% of patients have to wait more than 2 years before being diagnosed, which is a huge problem because maybe we'll come to that. If you treat early, the prognosis is very different as compared if you treat late. So, then the patients arrive at the GP. If it's a good GP, he will say, okay, but maybe I should think about Crohn disease or ulcerative colitis, especially if there is a family history, for instance, And he can order very simple tests to look at inflammation, for instance, in blood, such as C-reactive protein, and in stools. We have a very good marker of inflammation, which is called calprotectin. And if it's positive, then he needs to refer to the gastroenterologist who will make the diagnosis mostly based on colonoscopy, plus biopsies and cross-sectional imaging, a CAT scan or a MRI.
How do you view risk stratification in this disease? How do you look at these biomarkers, the endoscopy? And then when we go on to therapies, how do you use biologicals? But first with the risk stratification.
This is again, a very good question, which is still a big challenge for us. You are absolutely right. And this is what I always start with when I'm talking to my patient, because very often they come to me with an early diagnosis of Crohn disease and they are terrified because they think that they will end with a bug or something, untreatable and so on. There are so many different diseases. I always tell them there are as many Crohn's disease as patients. All patients are different. Some patients start with a very mild disease, localized, and they will never progress, sometimes with nothing. This is mild. On the opposite, you have patients who are progressing very fast and can become refractory to all drugs. And to your point, unfortunately, up to now, we don't have a good biomarker to predict. We are mostly using our clinical sense, based on age at onset, the location of the disease, how the disease looks back at endoscopy, presence of some manifestation. For instance, when you have perianal manifestation in Crohn disease, this is bad, this is a red flag. So based on this stratification, then very often when we have bad prognostic criteria, we start what are called now advanced therapies as soon as possible. The main problem is that still a lot of patients first are not diagnosed and are not treated early enough. And for instance, very often they are started with ineffective therapy, or they receive multiple courses of steroids because the gastroenterologists don't dare to start the biologics and so on for kind of fear about those drugs, which are actually much less dangerous than steroids. And then, it progresses.
From what you say, for some parts, it feels like it's a very patient individual therapy, and it becomes very difficult to say, to extrapolate to a bigger population.
Yes, it's difficult, but remember, when I started, we had nothing. We had mesalamine and steroids and surgery. And this was in the 70s, early 80s. And now we have a lot of biologics. We enter this area of Star Wars, where we have drugs that can specifically target some inflammatory components of the immune system, the so-called cytokines, and they are very effective. TNF, IL-12, IL-23, and so on and so forth. So we have a lot of drugs now. So how we pick up one or the other drug, this is sometimes based on relative efficacy, relative safety, presence of disease outside the gut, and so on and so forth. But it's not always an easy choice.
So when I think ulcerative colitis, I always think 5-ASA and steroids, that combination, and then a step-up regime. Maybe that's traditional, but how do you see it?
You are right. So actually in ulcerative colitis, to start with, aminosalicylates are very effective, and this is almost always the first line, apart when patient is presenting with very acute severe colitis, where we start something stronger upfront. But aminosalicylates, combining very often oral and topical with enema or suppository, is the first line. And actually up to 40% of the whole population with ulcerative colitis, this is what they need their whole life, and they will not need to be escalated. But as soon as they are refractory to salicylate, then you introduce steroids. And steroids are good for a short term, but it's a milestone. As soon as you need to start steroid, very often you need, now I need to think about the so-called advanced therapies, biologics or small molecules.
So you wouldn't bring out the big guns of the biologicals from initial unless it was severe present?
Yes. In Crohn's disease, it's different because mesalamine is not effective in Crohn's disease. So very often we start with a short course of steroids to calm down the symptoms, waiting for the approval also by insurance, especially in the US, it can take time, of an advanced therapy.
I'm really interested in your clinical experience of how do you monitor disease progression? Do you look at transmural healing? Yeah. Do you look at the biomarkers? What gives you a sense of that something's improving or not?
So very important, when you make the diagnosis, you need the full assessment from the mouth to the anus. You need to know where is the disease, how bad it is. So you need an upper endoscopy, colonoscopy, imaging of your small bowel, now using MRI. And in Crohn's disease, you need to look at the perineum. And if there is any suspicion of perianal disease, you will do a pelvic MRI. This is your starting point.
Biopsies? Cool. From the colonoscopy, yeah.
Because you need biopsies to prove that this is a chronic disease, with sometimes a hallmark of Crohn's disease, which is called a granuloma, which is a cluster of immune cells. So this is your starting point. At the same time, you measure biomarker, CRP, calprotectin, and more we are using ultrasound, especially when the disease is in the small bowel, just to look at inflammation as well. Then we follow the patients. And very importantly, now our target has changed. In the past, we were very happy when we were able to bring the patient in clinical remission, meaning no symptom, normal quality of life. But we realize that with the new drugs, we can do much better. We can bring the patient in deep remission, beyond clinical. It's like an iceberg. Clinical, endoscopy, and histological remission. And we have data now showing that if you're able to go down this iceberg, this is associated with better long-term outcome. So that means that if you start therapy after 6 months to 1 year, you need to repeat not only your clinical assessment, but endoscopy and take biopsy. Okay, is a drug really working? Of course, in the meantime, you can't repeat a colonoscopy too often. So more and more, we are using what is called non-invasive monitoring with blood biomarker, stool biomarker, and ultrasound.
So are you talking about repeating the medicine? From what I've read, I also know that it's not always a life sentence, you say so, that there's also reducing of medication or sometimes even stopping medication.
This is a good question again. You know, when I start this medication, also because of lack of knowledge and fear about biologics, you know, people are afraid. Very often the question is coming, okay, I'm okay to start, I understand I need to start, but when I will be able to stop? Unfortunately, the current answer is that we don't know. And very likely you are not able to stop. You know, because if we are able to bring you in remission, the drug is working well with you, because all the drugs that we have are globally safe, you shouldn't stop. Because if you stop, yes, sometimes you will be okay, but the risk of relapse from some studies that we did is approximately 60% within 2 years. Okay, so that means that with the current knowledge that we have, if we start medication, you need to continue.
I got a question then specifically for the more complex phenotypes. For example, if you had perianal fistulas, how does that look like in the greater team of care with surgery, with maybe even nutritionalists, general practice, help at home? What's that care team look like and how does it work?
Okay, so perianal Crohn disease is certainly one of the worst manifestations of Crohn disease. Again, not all perianal Crohn disease are the same. You have simple fistula, but you may have complex fistula with draining, abscesses, and so on. And you can understand when you have perianal Crohn disease, you are in your 20s. I think this is devastating for many obvious reasons. This is a combined approach with a surgeon and the doctor combining drugs that can work and some therapeutic, some surgical intervention to drain the fistula, to avoid the formation of abscesses and so on and so forth. I want to prolong your question about the care, and I'm very strong on that. I want to insist on that. When I meet with the patient, I always tell her or him, I want to treat your gut, but not only your gut. I want to treat you as a human being. This is why, actually at Sinai, we have what we call an IBD home, meaning I am part of the home, but there is a surgeon, there is a nutritionist, there is a social worker, and there is a psychologist. Because this is what we call the full circle, you know, the 360 care, because you are right, the nutrition, for instance, is key. What can I eat? What should I avoid? If I want to gain weight, or sometimes if I want to lose weight, because actually we have some overweight patients with Crohn disease or ulcerative colitis. Psychology is very important, in these young patients. How can I learn how to cope with the disease and learn resilience? And we have a full program with that. Also, in US with a social worker, who can help, to get the drug approved and so on, because you know that it's not always easy for financial reasons.
So I really like how you describe the full 360 package, you say so, as I do, understand why it affects all parts of a person's life. In an ideal world, or maybe in an ideal medical world, how would you implement this in a care structure?
You are right. And, this is killing me because, unfortunately, the care, for instance, that we can provide in a center like here, AMC or Mount Sinai, this is highly specialized center where we have access to the best specialists, the best people, nutritionists, psychologists, and so on. But this is just in some centers. And this speaks to inequality. So meaning that if you are diagnosed with Crohn's disease early and treated very early, for instance, at UMC, your prognosis is not the same that if you are diagnosed in the middle of nowhere, even though in the Netherlands it's not such a big problem because it's relatively a small country. But I can tell you in the US, it's a huge problem. You have a lot of patients who are in limbo because they have no access to gastroenterologists, and then again the care is delayed. And this is a big problem. And I don't know how to solve this problem. Because we can't obviously see all patients, in a specialized centers. So we are trying to establish networks between referral centers and community practices, but it's not always easy. The
limiting factors then finances are...
The limiting factors are also that I can speak about the US. The limiting factors is that the IBD patients are seen as relatively complex patients, and GI doctors are not very comfortable in treating those patients. For instance, they don't dare to start biologics, and because they fear some hypothetical side effects. And, they are so busy doing colonoscopies for screening and so on and you need time, and this is something striking as well. When I meet with a newly diagnosed patient, I spent 1 hour.
Wow.
But I have the luxury to do that because I'm not under pressure. And very often I ask, and sometimes, very often they are coming with their diagnosis. And I ask them, what do you know about your disease? And I'm showing them, this figure about the gut, from the mouth to the anus. And do you know what this is? Show me where is your disease. Blank. They don't know.
So the role of patient education.
What do you think is the cause of the disease? What do you think about if you want to be pregnant and so on? So many questions. So you have to spend a lot of time, especially the first one, when you meet, and you have to calm down. Because again, a lot of patients are coming super anxious because they are not very well informed. They go to internet and they see crazy things about the disease.
I've got a bit of a side question. You've mentioned a few times that biologicals aren't so scary as you think. But when I hear stuff like TNF alpha inhibitors and such, and I think if I did this in clinical practice, would I do tuberculosis screens? It doesn't open up a whole bunch of doors that might be really tricky to manage. And I can understand why people might be quite...
Yeah, I understand. And it's true that, especially with TNF, with the new biologics is less a problem. But with TNF, there is definitely an increased risk of infections. There is a possible increased risk of some cancer, especially skin cancer. But again, it's all about prevention. Let's check, be certain that you are not at risk to reactivate tuberculosis by doing a simple blood test. Let's be certain that you are up to date with all your vaccine. And we start with that, are you up to date with all your vaccine? Yes or no? And then remember, you have a small increased risk of skin cancer. The absolute risk is low, and very often I give figures, like 1 per 100,000 risk, which is putting things in perspective. But okay, so just go to your dermatologist once a year, as you should do, as I'm doing. Same.
Yeah. Not the Netherlands, we don't do that.
Oh, you should.
Yeah. So I think if we structure this just off the record now, but if we structure this, I would like to ask a little bit, okay, like the acute situation and what's the biggest mistakes that are made, and then look a little bit into the future with research, new developments. In a situation, and there's a medical student or a medical resident who has a patient with an acute severe ulcerative colitis exacerbation. Let's say they come in the middle of the night. What would you need to get right in the first 24 to 48 hours? And what are the biggest mistakes?
First, as soon as it's let's take the patient with acute severe colitis. This is a risky situation, especially of losing the colon. Okay, so first thing, hospital. This is a patient that needs to be admitted. As soon as he's admitted, okay, so we check for his vitals and so on, and we check inflammatory markers. Very often we do a colonoscopy to evaluate the severity, and we check his nutritional status, and we start medication as soon as possible. At the same time, we call the surgeon.
Yeah.
We call the surgeon because, and this is what I tell the patient, very likely you will not need this guy, but I want to bring him or her in because you never know how that can progress. And I don't want you to be in the middle of the night in the OR without knowing what's going on. So the surgeon will come and explain to you what may happen. Will likely not happen, but it may happen. Right? This is very important as well. And then you need to prevent thrombosis. These are the current management of acute patients.
Yeah, okay.
And then you need to evaluate rapidly if the patient is responding to the medications or not. If not, you can escalate to a second line. And if he's not responding to a second line, then it becomes tricky. You can go to a third line, but very often the surgeon is coming sooner.
And so then the biggest mistakes, I would imagine, then are not escalating quick enough, not getting the consults in appropriate time, and
yes,
yeah, okay, not then maybe
exactly.
Appreciating the severity of the disease.
Yes.
Okay. I want to look a little bit into the future of the field, especially looking at the development of precision medicines. How close do you think we are to having precision medicines for these inflammatory bowel diseases and in general?
Precision medicine is a kind of wild term when we think about precision. We already mentioned predicting the course of the disease, which is difficult. Second aspect, predicting response to one or the other treatment. So far, nothing. Unfortunately, everybody, when I give talk, I always say this is a Loch Ness monster of IBD. Everybody's talking about it, but nobody has seen it. And then, of course, you are now touching my dream, which is the possibility to predict and to prevent. Because, again, it's all about early. So what if even we can treat earlier than early, meaning before the first clinical symptoms, to prevent the occurrence of the disease? I mentioned that this is already done in diabetes, for instance. In type 1 diabetes, now they have biomarkers that you can test in family members of patients with diabetes, in kids. And when you have those biomarkers, you know that the kid is likely to develop with a likelihood of 75-80%. Then you can prevent with some medicine now. And this has been approved in the US. So this is exactly what we are currently now doing in Europe as well. I've been working on that for many, many years. So bottom line, what we need to do is to find preclinical biomarkers in blood, in stools, or others to predict the development of the disease. We need to find therapeutic targets that we could actually target before the disease is occurring. You need to build a risk score, meaning that, for instance, I take your blood, I'm telling you, you know what? You have family history of Crohn disease, your blood risk score is 80%. You have 80% chance that you will develop Crohn disease within the next 2 years. And I want to give you a preventative measure. And there are different kinds of prevention, depending on the risk. At the population level, we can already do something, For instance, avoiding excessive antibiotics, a good diet, for instance, avoiding ultra-processed food and so on. It's not specific to IBD, but this work. Pollution may also play a role. So, there are some general measures that we can apply in the general population. If you have now a little bit higher risk, for instance, your son or your brother has Crohn disease, you are already in the little bit higher category. Then you can do something more proactive, like being on a Mediterranean diet, but very more strictly, and of course avoid smoking. And then if you are at a very high risk, this is where we are now starting in Europe the first prevention study with a drug, actually, with a drug that works for Crohn disease, is very safe, it's called vedolizumab, and that we are now trying to use to prevent the onset of the disease in very high-risk people.
Vedolizumab is an anti...
No, it's not an anti, it's a drug which is specific to the gut, and there are several mechanisms of action, but bottom line, it blocks the recruitment of bad cells from the blood to the gut. Okay?
Yeah.
And this is nice because it has no systemic impact, so no risk of infection.
And what's the bad cells specifically, sorry?
I mean the inflammatory cells like lymphocyte and so on.
Okay.
I did have a question. Do you take into effect the environmental effects on the biomarkers?
So we don't, because when we measure the biomarkers, actually when you have a biomarker, it can be the result of your genetic predisposition and your past exposure to environmental factors. For instance, if you have a bad microbiome, maybe it's because you received too many antibiotics when you were young, or maybe because you have been exposed to some pollutants, things like that. So the biomarker actually just a trace that maybe because of this exposure, you have now this biomarker which reflects something which is happening in your mucosa, in your microbiome, in your immune system that actually with a new trigger can lead to the clinical development of the disease.
A bit more broad questions now, but looking back on your career, is there anything that you'd wished you'd understood earlier about academic or clinical medicine that you would go back and tell your young self that would have helped you?
I have spent my life mentoring fellows from all over the world. And I always say that at the end of my career, this is the only thing that will say, I've published, I don't know how many papers, whatever, it doesn't matter. What will remain is a life of people that you have changed. Your patients first and your fellows, because then they will remember you. So other people, the scientific world, they will forget about you within 6 months. Believe me, I am 100% convinced. It will go to the garbage of history. But the life of people that you have changed, that will remain forever. First thing. Second, I always tell them, if you want to make a difference, the two most important things for me are, first, network. Work with other people locally, with your friends, with your colleagues, gastroenterologists, but look beyond. Discuss with pneumologists, cardiologists, rheumatologists, because you may get some very interesting concept and bring back those concepts back to gastroenterology, and then you will make a difference. And foremost, think outside the box. Think about something different. Especially look at what is done outside gastroenterology, what is done outside IBD. Find new ideas. If you are not thinking outside the box, you will be a follower. And you can make a good career, actually. There are a lot of followers, which is good. But if you really want to be different, you need to be innovative. And at the beginning, maybe people will say, this guy is crazy. But at the end, I remember when I started to discuss about prediction and prevention of IBD 15 years ago, people were laughing at me, or I say, this is, I will not say the word, but this is BS basically, right? And they didn't believe it. And now it's blossoming. Everybody is talking about that. And this is very important. And it's very important also to stay acquainted with basic science, especially those days, because the progresses are amazing. So you need to work with basic scientists. And also something that for you guys, and maybe you can teach me about that, you need to understand about AI, and so on, because this will make the difference as well. Because there are so many data that you can bring together and make new hypotheses. For me, it's a little bit too late, but not for you.
After listening to you this hour, I was also very curious because you talk so passionately about it. What brought you to this research?
It's interesting. Some people say, when I was young, I wanted to be a doctor. When I was young, no. Actually, I went to medicine by chance because I didn't know what to do after my baccalaureate, which is in France, the end of high school. And some of my friends went to medical school, so okay, I will go with you. Second, I started gastroenterology also by chance because I didn't know what to do. And third, about IBD, this is different. When I arrived in the gastroenterology unit in Lille Hospital, where I started my career, I realized that there were a lot of young patients coming with this disease. And very interestingly, this was the beginning. This was the beginning in the 70s. And then I said, okay, I think this is interesting. We should start looking at those people and understand. And I had a very good mentor, Professor Cortot from Lille, very good mentor who helped me, guide me, and so on. And this is something very important as well for young people. You need to be certain you have a very good mentor.
And how do you do that?
It's just a kind of feeling, and a very good sign about a mentor is when you realize that he's not upset when you are becoming better than I think this is very, 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 very good sign. And for me, I see some of my fellows and, oh my gosh, they are like, sometimes I can't follow them, and I say, this is amazing. I love that. But, some people don't like that because they feel challenged.
I think a final question from me would be also looking back, what's your favorite failure or mistake that you've had in your career, and what did you learn and reflect from it?
I regret not to have more knowledge in basic science.
And you mean by that the pathophysiology?
Immunology and so on, because I know but little bit superficial, and I wish I could have more deep scientific knowledge. I understand very well the clinical part, but the basic science part, I understand.
Yeah.
But it's still a little bit superficial. And sometimes I feel this lack of knowledge.
Merci beaucoup.
Well, yeah, then we want to thank you enormously for your time. It's been a real privilege. And we wish you the best of luck in the days in Amsterdam.
Thank you so much.
Thank you.
Merci pour l'accueil.
Thank you.
Thank you.